now showing us live on Facebook. So I will hand you over to our Chief Exec, Collette, who will introduce our guest medic today. I hope you all have a very good session, and I'm sure, as always, will be very informative. So I will catch up at the end of the session.
Thank you, Alan. Good afternoon again, Vinod. Good afternoon, everybody. We have Dr. Vinod Hegade with us, so a very old friend of the foundation, although he's a very young man. And he is a consultant hepatologist at Leeds, St James's in Leeds. But we knew him from his days in Newcastle when he was a very junior doctor. He's a very senior doctor now. So anyway, welcome, Vinod. So everybody, thank you for your questions. I'm going to take the paper ones first, and I'll come to the screen. And then, but any questions, please keep them brief and don't write War and Peace, because we've only got a certain amount of time. So here we go. Are you ready?
Yeah.
So you're not coming over very loud, so I don't know if you can switch up some volume, Vinod.
Probably I can do something about that. Give me 1 second.
Yeah. No. No.
Oh, I'll tell you what. It's this one.
Ah, yes, that's much better.
Right.
Hey, oh, where have you gone? Yeah, there you are.
Better? Is it better?
Yes, perfect. Thank you. Okay, so good questions to start with. It seems, universe, that coffee is good for our PBC liver. Does it have to be black coffee? And if it is black, why? And can I add something? No sugar, of course, maybe soya, almond, or oat milk. So we know that it's not the caffeine, so you can have caffeine or decaf. What about the milk? Does it make any difference, Vinod?
Okay, let's take a step back. I'm not aware of any particular PBC study which has looked into caffeine intake and PBC and fibrosis. Having said that, there are some general, like fatty liver, NAFLD, non-alcohol fatty liver disease type of studies where people have looked at caffeine intake and reduction of fibrosis. You got to take the results with a pinch of salt, because these are not randomized control studies. These are just epidemiological type of studies, questionnaire based, where they ask few thousand patients with fibrosis and ask their diet history and how much coffee they drank. So most of these studies have shown that caffeine has got a protective effect on the liver, as in it reduces fibrosis and it does something good to you. But none of these studies have answered the question, how much coffee do you have to drink? Is it 3 cups, 4 cups, 6 cups? We don't know the answer. And there has been, at least to my knowledge, there has been no specific study in PBC regarding caffeine intake and reduction of fibrosis. Some people say it is caffeine, so there has to be caffeinated drink, not decaf, because caffeine is antioxidant, it reduces inflammation, it reduces fibrosis. There are other compounds that have been detected from coffee which are showing similar effect, like leptin. There is something called leptin. Leptin is also anti-inflammatory and antifibrotic. So there's definitely positive result, but not specific to PBC.
Yeah.
Any patients with fatty liver disease, fibrosis, drinking coffee is good. But that's all we can say at the moment, because we need more studies.
Somebody did come in this platform, one of the doctors, and say 6 cups a day, which is quite a lot of caffeine, particularly if you're taking it later on in the afternoon. It can stop you sleeping, but I can't remember which one it was. But that's helpful to know anyway.
Yes.
So does this lady put milk in her coffee or not? From what you're saying, why not?
Why not? Exactly. Yeah. Why not? There is no evidence to say that putting milk, soy or almond milk, is going to dilute that effect of caffeine. Yeah. There's no evidence to say that. So yeah, go ahead. If you don't like black coffee, put some milk in it.
Oh, I like it black. I do like my coffee. I have to get up very early in the morning so that I don't get the kickback at night. Anyway, okay. So now I don't always necessarily understand the questions I'm asking you, Vinod.
Yeah.
So this person's PBC for 5 years, and so far results have stayed relatively stable except for CRB latex, which has gone up a bit. what is the normal CRB latex blood result for people with PBC?
Do they mean CRP, C-reactive protein? I don't know what CRB means. It's
Right,
CRB
let's
used to
give
stand
them
for
an
Criminal
answer
Records
on it.
Bureau.
Let's assume it is CRP then.
Yeah, if this person meant CRP, it's a C-reactive protein, which is a marker of inflammation. It's a very non-specific marker of inflammation.
Okay.
We do not use it in PBC in any particular way. CRP is commonly monitored if you have infection, sepsis, if you're on antibiotics, or if you have any inflammatory condition like arthritis, rheumatoid arthritis, septic arthritis.
Yeah.
But to answer this question particularly, there is no reason for you to worry about CRP and PBC because there is no correlation. We don't need to look at that.
Okay, and I know they look at different things in different parts of the world. We had, do you know Robert Geish, Dr. Geish?
Yes.
From the States? So he was in last week, and so he was telling us something. I don't think I would like to be his patient. He's so thorough. He wants to know everything.
Yeah.
Anyway.
No, in my practice, at least, I don't check patients' CRP unless they have, as I said, infection or if the CRP is very high and you give them antibiotics for infection, we use CRP as a marker of improvement. If the CRP is 100, which is very high, normal CRP, by the way, should be less than 10 in anybody. So less than 10 is normal. Some labs say less than 8, but anything more than 10 is high. And I've seen very, very high CRPs when somebody comes with a raging infection or sepsis, pneumonias, urinary tract infections, those kind of things.
Well, that's pretty helpful to know. Thank you. The next question I don't really understand either. I have AFib and I've been prescribed a blood thinner. Do they affect AVC? I don't know what's AFib.
Atrial fibrillation.
Oh, right. Of course it is. Yes.
So atrial fibrillation is where your heart is not beating regularly. It is all doing chaotic rhythm. It's beating irregularly. And those patients have a very high risk of stroke. So because they get clots in the heart and that can go to the brain. So routinely atrial fibrillation patients are put on anticoagulation to reduce the risk of stroke. So they usually give they used to get warfarin, but now there are other novel anticoagulations like dabigatran, apixaban, and all that. So to answer this question, do they affect PBC? Do you mean atrial fibrillation affects PBC? No. Do you mean anticoagulation affects PBC? Not directly. It doesn't make your PBC worse or better. But I guess if your PBC is worsening, these medications, the anticoagulations, can affect the blood tests that we measure. For example, prothrombin time, INR, these are the markers of your liver disease. So some of these medications can interfere with them, but your doctor will be aware of that. Your gastroenterologist or hepatologist will be aware of that. So you don't need to worry about it.
That's excellent. That's quite good because we do get other things, and it is a worry, and it's great that people can come along here and just have a bit peace of mind, which is priceless. Okay, so I've had bad fatigue and brain fog along with joint muscles aches, etc. Positive ANA at 1.1280 with nuclear dot and positive AMA M2 of 62. Elevated GTT, which is 107. But my LFTs are all in the normal range. The question is, 2 questions. If this is enough criteria for a PBC diagnosis?
Well, if your alkaline phosphatase is completely normal, even with that when they say my LFTs are normal, I assume that your bilirubin and your alkaline phosphatase are normal. And if they are normal, you having the antibody does not give you PBC diagnosis. So as you know very well, to diagnose you of PBC, you need to have antimitochondrial antibody and you need to have elevated alkaline phosphatase, not gamma GT, alkaline phosphatase. So there are very specific criteria for diagnosing PBC. So this person, based on what they have said, I don't think I will confidently diagnose PBC. So I would like to see their alkaline phosphatase. I would like to the antimitochondrial antibody is positive, okay? So that gives them 1 out of 3 criteria. There are 3 criteria. AMA, alkaline phosphatase, liver biopsy. You need to have 2 out of 3. So you have antimitochondrial antibody, but what's your alkaline phosphatase? Assuming it is normal, if you really want, you need to have a liver biopsy, which we normally don't recommend unless your alkaline phosphatase becomes high. So,
yeah, because liver biopsy, it does have its risks. A lot less risk than what it were years and years ago. So I would say to this person, maybe you could let us know what your ALP is, or if it's normal, if you said that's that's good. And the gamma GT, just roughly the GGT, I mean, if somebody's overweight, they have a bit fat in the liver and what have you, that can push all that up too, can't it?
Absolutely. I mean, gamma GT is not a very specific marker. It is a marker of certain things, but we don't rely on it for PBC patients. As you said, if you have fat in your liver, if you're drinking a bit of alcohol, alcohol can make your gamma GT go up. Fatty liver can make it go up. And there are some medications which will raise your gamma GT as well. So I would suggest don't look at your gamma GT, look at your alkaline phosphatase.
It's an interesting one because I'm just going to mention this briefly. We all know people are carrying a bit of COVID weight, and I'm not fat shaming or anything here, but we have to keep an eye on our weight, and it can and does affect our liver. Just because you've got PBC, it doesn't mean to say that being overweight. And I can say to you, I mean, I've lost 3.5 stone now. And my gamma GT dropped like a stone right back into normal. So and that was nice. I was pleased with that. So losing a few pounds, if you've gained a few COVID pounds, it's going to make a difference. And it's also nice to know that you can do things to help yourself. I think it's a very, very powerful thing. Okay. So this question was asked last week, but the member would like a second opinion. Okay. So this lady, now I know this lady's in the Republic of Ireland.
I see.
So she's diagnosed last October. GP says, I don't need medication. I'm not being referred to a specialist. Bloods to be checked in a year. Have no symptoms. Great. And PBC discovered by chance. Now, the ALP is alkaline phosphatase 112, GTT is 41, bilirubin 15, ALT 24. I can't approach GP to tell him I should be a nurse. So he is sensitive about being told his job. Now, before you answer that, let me say to this person, so what if he's sensitive? I'm sorry, his job is his job, right? You're not there to consider the feelings of your doctor about any discussion you may have. He's highly trained. He's trained to do a job.
Yeah.
Be as open as you need to be. Doctors are not gods, they're human beings. And, he might just welcome the discussion if there is a discussion to be had. So over to you, Vinod.
Well, I need to be a bit careful here because this question was answered by an expert last week. So they tell me. So I don't know what advice was given last week, and I don't want to contradict that. I think
the advice was to go and have this conversation with the doctor.
Okay, I would like to know a little bit more here, because if this person was diagnosed of PBC in October, I would like to know what was the alkaline phosphatase at that time. Because if alkaline phosphatase was normal at that time, and it is normal now, I can see that ALP is 112. That means this person does not need ursodeoxycholic acid.
Right. Okay.
But if the alkaline phosphatase was elevated at some stage in the recent past, then yes, they need to be on urso. So again, it all comes down to what is your alkaline phosphatase doing with your PBC diagnosis. So there are a lot of people who have antimitochondrial antibody in their blood, but they're completely normal alkaline phosphatase. We do not give urso to them. Guidelines are very clear. Patients or people who have AMA positive, normal alkaline phosphatase should not be given urso. You only give urso when your alkaline phosphatase or ALP goes above the upper limit of normal, which in most hospitals is 130. This person's alkaline phosphatase is 112, normal bilirubin, normal ALT, normal gamma GT. So your GP is probably right that you don't need any medication. Having said that, please go back and check what was your alkaline phosphatase in October. And if it was normal, just be reassured that you don't need a medication. Have an annual blood test. That's what we do to our patients here in Leeds, that such a group of people have an annual blood test, monitor their alkaline phosphatase, and if ALP goes up, we put them on urso.
Okay, I think to this lady in Ireland, I think that's really reassuring what Vinod has said. But don't be intimidated, or don't be worried about your doctor's feelings. He's not gotten paid to have his feelings sheltered, and he could just welcome the conversation.
Yes, absolutely. Yeah.
Would you not agree?
Absolutely. A good clinician always likes a bit of a challenging, patients should be able to feel comfortable to discuss their disease or symptoms or whatever with the GP or with the clinician. You should not feel embarrassed, or you should not feel, oh, what is my doctor going to feel if I keep going to him? That should not be the way. You're absolutely right, Collette. You should be feeling confident enough to initiate a conversation about anything, because it's your disease, it's your body, and you need an expert or an opinion. So feel free.
Yeah, great. Well, I'm glad you said that. And I don't like demonizing doctors as well, I mean, some are a wee bit off, but then so are accountants, lawyers, and shopkeepers. You know what I mean? We're all human beings at the end of the day.
Yeah, but what you don't want is, you don't want to pester your GP every week about the same thing, because that's not needed. You need a good consultation for 15-20 minutes, taking all the information into account. Your GP tells you certain things. He or she, your GP, may be knowledgeable about PBC, and if they tell you something, just go with it. As long as you're monitored,
And also, what he doesn't know, he will certainly know where to get information from.
Correct.
Yeah. Correct. So okay. So I have a question. I did laugh when I read this, but I shouldn't. I have a question about losing libido since being diagnosed with PBC is a bit of a taboo subject. Let's not make it taboo. But I'd like to know, has it happened to anyone else? Is there something you can do to get back? Now, if I may just a couple of things here. There's something called the PBC 40, which you can ask your specialist about. And in the PBC 40, it's a questionnaire. It's put together by ourselves and Professor Jones and others, basically assessing your quality of life to do with your fatigue, etc. And libido comes into that as part of the questionnaire. So it's not taboo at all. And doctors do understand that you can lose your libido for a huge number of reasons, and it can go and come back, and there's lots of things involved. You've got menopause and all sorts of things. If you're a woman, I don't know, but there is one thing I would say to you, that, and I'm going to hand you over to Vinod, that when you're diagnosed with PBC, you probably haven't heard of it before, you won't know much about it. It's a shock. And it does take a wee while to get your head around it. You've got information to glean, you've got confidence to find, which you get with your medical help and hopefully with our help. And it's no surprise whatsoever. And sure, it can come back, but it's just finding out where you have your PBC, how you feel, and has your confidence come back a bit, because first thing normally people say to me, how long have I got? Well, given I've had PBC 28 years and I'm still out on my bike and doing various things, how long is a piece of string? But these things can affect us emotionally and psychologically, and of course they appear physically, if you know what I mean. I'm not putting this very well. All I'm saying is this is a bit of a journey, and your confidence can, and I'm sure, will come back. But I'm sure you've got things to add to that.
No, not more actually. I think you've covered it very well, Collette, because PBC, as you said rightly, whenever we tell them that they have PBC, it does come as a shock. And it is a chronic illness, it is a chronic disease, and that information, that new knowledge that you have a liver disease that you have to live with for the rest of your life, does have a psychological impact, and that does play a role on your libido or sexual drive and all that. That's absolutely true. But slowly, as you come to terms with the diagnosis, and depends on severity of your PBC, it's not all doom and gloom, is it? There are lots of PBC patients who enjoy a full life. They go and have family, children, and all that. It's not a cancer, is it?
That's right.
Not like cancer diagnosis, where 20 years ago, when we say you have a cancer and you have 6 months to live, we don't say that to PBC patients, do we? But coming back to libido, yes, go and have a chat with your GP. There may be other reasons for reduced libido. If it is just PBC that is affecting your libido, then you need to get sorted from PBC point of view. And if you have stable disease, if your disease is not worsening, those are the positive things, and they should help you to cope with psychologically. In terms of treatment, yes, there are things. If you're a man with low libido, yes, you can have Viagra. Medications are available for erectile dysfunction. But before that, lots of other things can be done to improve your sexual drive, I would say.
I would say to this person as well, the office answer machine, if you phone after hours, my personal mobile numbers on the answer machine, feel free to give me a ring. You don't have to give me your name, just let me know you were the person that put this question in today, and I'll help in any way I can. Okay. Right. Oh, right up your street now. Can you recommend anything for the itching? I'm a nurse on the sachets you mix with water that taste like wallpaper. I wonder what they are. Now, I have to tell whoever's asked this question, our itch expert is in the room with us now. Over to you, Vinod.
No, thanks, Collette. No, I'm sorry you have to take that paste, which is absolutely awful. I know. But unfortunately, that is the first medication we give. This person is talking about cholestyramine, or Questron, we call it. It is the first line medication for itch in PBC. Tastes absolutely awful. I would say try to make it palatable. You put it in cold water, you dissolve it. You can take a jug of water, dissolve the sachets, stir it, put some ice cubes in it, keep it in the fridge. Keep it in the fridge overnight and drink it in the morning. You can make it a little bit more palatable by adding a dash of squash or lemonade or something. Just make it a little bit more palatable. I know it tastes disgusting, but anything you can make it drinkable, please do that. Because, as I said, it is the first line medication. If you come to me with PBC and itch, that is what I'm going to prescribe it to you, at least for 1 month. You try it for 1 month, and if you don't like it, or if it's not improving your itch, then we go to the next medication. So I don't know how long you have taken this Questron medication. If you have not taken it for a month, I recommend you please take it. And the dose can go from 1 sachet per day all the way up to 4 sachets per day. So if you're maxed out on that, if you have used 4 sachets per day, but still itchy, then yes, there are other things that we can do, like rifampicin, sertraline, bisafibrate. There are other medications that your your hospital consultant will be able to give you. So please come back to this forum in a month's time. Let me know whether you have tried Questron for a month, and if it has not worked, I'll recommend something else.
Great, there you go. Good answer. Wee bit background here. It's about fainting. Faintness, I experienced the sensation intimately many years ago before being diagnosed with PBC. Doctor and gastrologist, I've not found any clear cause. I now experience daily tiredness, faintness frequently, accompanied by slightly numb hands and wrists. I was also experiencing day and night tiredness and joint pain. Take Ursula described, 63 and active, fantastic. And due to the symptoms, I have finally had to take an illness break from work. Listen, I'll just say before I hand you over to don't take that as a negative. Sometimes it's really good to just have a complete break from work when you're struggling with things, because if not, struggling on, it can exacerbate, exhaust you, and cause all sorts of problems. So don't. I think it's a great thing when people take maybe a month, maybe even 2 months if that's what they need from work. So they're saying, I wonder what next. I would appreciate advice. I don't want to stop working or give up an active lifestyle. So no, don't do those things, but take a pause.
Yeah. I mean, fainting is difficult, isn't it, Collette? The whole fatigue, the brain fog, the autonomic dysfunction symptoms of PBC, very difficult to manage. But the approach to this is quite systematic. You need to make sure your blood pressure control is good. First of all, your GP should make sure that your blood pressure is checked on lying as well as sitting up position. And if there's a huge drop in your blood pressure when you stand up from sitting position, that suggests something called as postural hypotension, which means your blood pressure drops when you stand up, and that can contribute to faintness. And if that is the thing, then there is a medication available for that called fludrocortisone, which your GP may be able to give you. You need to drink plenty of fluid. You need to keep yourself hydrated, because the blood pressure fluctuations could be because of fluid, not enough fluid in your body. You should make sure that after every few hours or 1 or 2 hours, you should sit down. You should elevate your feet, make sure there is good circulation to your body. Avoid standing up for too long period of time. So sit down very frequently. So these are the simple measures that you should do to reduce the faintness. Okay. Then the second thing I need to know is whether you are on medications which can cause blood pressure drop. If you're taking antihypertensives or other medications which can drop your blood pressure, it can contribute to faintness. But if all these are addressed and things are still not improving, it just reflects that you are one of those patients who have significant autonomic problem in PBC, for which there is no cure or treatment, but we may be able to just give you some general advice and let you get on with your life. So that's all I can say at the moment.
I'm going to pick up on something you said, Vinod, about drinking enough.
Yeah.
We are a nation of prudence. We are dehydrated a lot of the time. And Linda in the office has got this lovely expression. She says, if you imagine a plant that's not been watered and it's withered and dry, and you start to water that plant and it comes to life. I am a big, big believer, and I have these. This is water. I have 6 or 7, 8 of those a day. It's great. It's good, and it's good for your complexion. And I had an incident about 2 months ago, and I was, if I know it was last summer. It was hot, and we had no water for about 4 or 5 hours. And I came home, I could barely speak, and I didn't know what was wrong with me. My husband said, "When did you last have a drink?" And it was hours and hours, and it took 5 pints of water, not all in the 1 hour. A couple of hours before I actually felt that I could speak, and that it was just to watch the dehydration thing. And too much caffeine can dehydrate you as well. So just plain tap water. We are so lucky we've got tap water in this country, and it's great. Every time I go, I think it's wonderful. Right. So background, current medication for the itch, rifampicin. Well, you've got the doses there 2 times a day. Gabapentin, sertraline, which you'd already mentioned, but can use 50 milligrams when it's stressful occurring. I can feel the skin prickles. Oh, bless you. How long before the end of the studies into itch and the medication becomes available? Is it like that? I have doctors change medications so a patient is stable on a cocktail such as mine. I think this lady should probably she feels she's taking a lot of medication, and 1 tablet obviously would be better than
No, I'll take the second question first. If you are established on these 3 medications, rifampicin, gabapentin, and sertraline, and your itch is manageable, then we wouldn't change any of that. So we don't rock the boat, Itch is a very difficult symptom to treat, and it takes trial and error to find a particular combination of medication that works for the patient. And if this cocktail regime has worked for you, and if you are my patient, I wouldn't change it. I would just leave you. You're on good medication. Rifampicin, 300 twice a day, gabapentin, sertraline. Perfect. That's exactly the combination that some people respond to. So keep taking it. I don't think your hepatologist should change anything if you're stable on it. Hope that answers the question. The second one, how long does the studies, you probably are referring to the GSK study, which has gone into phase 3 now. I don't know. I think the COVID has affected the recruitment of the trials. We may get the medication ready by end of this year or next year. Then they have to apply for FDA approval and NICE guidelines and all that. So possibly you're looking at another 2 or 3 years before any of these new anti-itch medications become available. I'm also waiting. I'm desperate for a new medication that I can prescribe to my patients. But I guess we need to wait till another 2-3 years.
Just to give you heart, everybody, GSK are working very closely with the foundation and Chris in the background there. And they are and I remember being at the initial launch of this, David Jones and I went down to Stevenage, very, very keen to get on with this. And so what they've asked us to do is to give them 5 or 6 people who are suffering it, and they're going to film these people, talk to them. And so they really are, GSK are all over this, aren't they? I mean, they're working so hard in the background. So Fingers crossed. We're on it. We're on it. I can assure
We are,
you.
and they've just completed 130 patients recruitment, which is amazing. I cannot remember a PBC study with a symptom which has recruited 130 patients in the whole world. That's going to be a fantastic study to publish. So it'll be ready hopefully in the next couple of years. This new medication.
Well, pharma, we've got a lot of interest from pharma this last year, in fact, and the questionnaires all the time, and it's been fantastic. And I would say to everybody again, I'm going to be constantly going on about the questionnaires. We've got them on SurveyMonkey, we've got them online, they're in the app. Please keep answering the questions. We will be bombarding you. The doctors want to know, the pharma want to know. The more they know, the more we can help you. And the bigger the number, amazing. But I'm just staying on the itch for a minute, Vinod. I wonder, and we don't know the answer, why some people just don't itch. They just don't itch.
No, we don't know that. Yeah. We don't know that. Good thing is 25% of patients don't itch, according to my study. So if you take 100 PBC patients, 25 of them say itch. No, I've never had it. I've had PBC for 10 years. I've never itched, which is good. One of the unknowns, many unknowns.
Yeah. But we're getting there. We'll know a lot more now than what we did when I started this 25 years ago. Right. So this is a person from Luxembourg. I've got AMA negative PBC since 2011 through a biopsy. All my blood exams are very good and unchanged. I take UDCA, good. But my values from elastography are increasing during the last 2-3 years from under 3 kPa to actually 4.7 kPa. So how do you know if your PBC is progressing? Doctor says a progression of PBC first affects blood values, then we don't have to change anything medication. Is that true? And other liver blood values, ALP dominant in the evaluation, which you've covered the ALP. So it's about the elastography that she wants to know.
Can I just reassure this person that her or his elastography is better than mine? 4.7 kPa is really good. It's really good. Mine is close to 5 when I last did my elastography. So you're good. Nothing to worry there. You got AMA negative PBC for last 10 years. I hope you're on medications. Yeah, you are on ERS. So, and if you are my patient, I wouldn't worry about you. Not with that elastography reading. 4.7 kilopascals is normal.
There you go. Fantastic.
So you don't have fibrosis. You
can't be normal and have PBC. You got to be very nice. Only nice people have PBC, of course.
Yeah. So how do you know it's progressing? Well, we do use elastography as a marker of progression. We do it every 2 years. And if the numbers are rising, of course, it suggests that fibrosis or scarring in your liver is increasing. But we also take other things into account. We look at your bilirubin. We look at your alkaline phosphatase, albumin. There are other markers. We don't rely on only one marker to tell us whether your PBC is progressing or not. So I hope that answers your question. And alkaline phosphatase and elastography are two different things. You're measuring two different things here. So please don't get confused. Elastography measures fibrosis or scarring in your liver. Alkaline phosphatase measures the flow of your bile or cholestasis. They're both very important, and we use both of them to understand your disease, your PBC. But in your case, in the last 10 years, your PBC has not progressed so badly. So be thankful, and I think you don't need to worry too much about it.
Great news. Fantastic. Now, this next one's a belter. This is a new one on me. Is it true that after you've had a liver transplant, you should not eat all processed pig, especially bacon? It has a risk of interspecies contamination with hepatitis E.
Interesting. The short answer is no. There is no contraindication for eating bacon. I'm just opening up what we give, because we are a transplant unit. We have a information sheet for patients who have had a liver transplant, and there is a section on dietary supplements and what kind of food items they need to avoid. Bacon is not on it, so that means you can eat it. What we generally avoid, ask them to avoid is shellfish, raw meat, like salami, pate, those kind of things we ask them to avoid. But I'm just scrolling through this. Give me 2 minutes. I'll come back to this. It's a long cooking. There you go.
I get you to ping that on to me. That might be handy for us to keep in the office if we get these inquiries, Vinod.
So we say avoid eating from street vendors, market stalls, avoid eating meat and poultry if it's not cooked at the right temperature. High-risk food. Hold on, there you go. So high-risk food in a post-transplant patient are raw meat and poultry, salami, pate, cooked meat from the deli counter, barbecued meat, presenting particularly high risk and is best avoided altogether. So those are the only 4-5 items, and bacon is not on it.
Yeah, great. That's a new one to me. But it says it came from the Solid Organ Transplant Authority.
Yes.
So I suspect that's not British, is it?
No, there is there is. So I think this person has received some advice, but it's not entirely true. But I can send this to you, Collette. And
yes, please.
You can send it to this person because this is our approved Leeds liver transplant units booklet that we give it to our post-transplant patients. I must say, shellfish, raw fish, sushi, smoked fish like salmon, they all come under high-risk food. So they should avoid it because of risk of hepatitis A.
Yeah, I grab that.
Yeah.
Okay, so the GI specialist I saw said that ARSO is not indicated until the ALP is 50% above the normal. I thought that early administration had a positive bit. Should I ask my doctor for confirmation?
Okay, so the simplest answer is if your alkaline phosphate is more than the upper limit of normal, you need ARSO, as simple as that. So this 50% above, I don't know what that means. So as I said, in Leeds, our patients cutoff normal alkaline phosphatase is 130. So anything above 130, if you have PBC, we start you on ursodeoxycholic acid. So we don't wait till the alkaline phosphatase goes up to 170 or 200. We don't have a cutoff. We don't have an upper threshold cutoff. We have a lower threshold cutoff, which is 130. Anything above 130 in the right context, as in you have the antibody, you have PBC, we give you ARSO. So perhaps we need to go back to GI specialist and say, what is your laboratory's reference value and what is my value? If my value is above the upper limit of normal, then they should be started on ARSO.
Yeah, and any difficulties, give me a wee ring at the office and we can send you some information. Right, I'm turning to the screen now. We've got these questions firing in. You're doing a grand job, So I'm going right to the top. Jane, can PBC turn into liver cancer? That's a belter of a question, and we need to keep them relatively short because we've got a lot to get through.
Simple answer is very rare. So I don't want all of PBC patients out there to worry about liver cancer. Liver cancer only happens once you have cirrhosis. Not all PBCs turn into cirrhosis, and not all cirrhosis turn into liver cancer. So if you look at large number of patients with PBC, only a very small proportion of them get cirrhosis, and only a very small proportion of those patients with cirrhosis get liver cancer. So yes, it can. It is a risk factor for cancer, but not all PBC patients develop that.
And in this country, if they thought there was any risk, you're given ultrasound every 6 months when there's any fibrosis. So you're well looked after here. I'm on 20 milligrams citalopram for depression and just wondered, is the dosage safe? Before you answer that, Vinod, anybody who's concerned about dosage or different medications and mixed, never be afraid to chat to your chemist, your pharmacist. These are highly skilled, qualified people, so never be afraid to discuss any of that with them. But I'll leave you to answer that question.
Citalopram, that dose appears safe to me. There's no concern with that dose in PBC. So your answer is yes, it is safe.
Caroline says, good afternoon. Good afternoon. Jane, do we need an MRI to determine how bad my bile ducts are damaged?
No. In PBC, I can't remember when was the last time I did an MRI. So we don't routinely do MRI scan for PBC patients. If you have primary sclerosing cholangitis, PSC, which is a completely different disease, yes, we do MRI scans. But for PBC patients, an MRI scan is not needed to determine how bad your bile ducts are. We can get that information from your blood test and from your fibroscan.
Excellent.
Do not need an MRI scan.
Joel says good morning. Joel's in the States. Good morning to you. Good afternoon. Jane says hi. Good afternoon from Nottingham.
Yeah.
Debbie says I'm on famotidine. That's good that I managed to pronounce that. 20 milligrams a day. Can I take a higher dose with PBC? I don't know what famotidine is for.
Famotidine is for reflux, Collette, acid reflux.
Okay.
So famotidine is like, ranitidine. So ranitidine, yeah, there you go. So Gaviscon. So famotidine is absolutely safe. I don't think there's any problem in you taking it with PBC. The usual dose is up to 60 or 80 milligrams, I think. So if you're taking 20 milligrams twice a day, you're fine. You can take higher dose. I have given patients 20 in the morning, 40 at night, or 40 BD or 40 twice a day, I must say. Yeah, you can.
Yeah, I think something I've heard too, sometimes when people have got to go on a wee dose of prednisolone, sometimes they'll either give them a meprazole or give them a bit more of these things. This is from Connie. Does stress affect your liver, the death of a loved one? Do you know, the death, I lost my husband is now, it's coming up 14 years ago. And my mum and my sister and my brother, and did it affect my liver? It didn't, but it affected all of me.
Yeah.
It's a difficult one, that, isn't it?
It's difficult. I don't think there's any study to say that,
No.
we will probably never have a study, but in a holistic way, when you look at it, when you're stressed or depressed, or if you're going through a difficult time of your life, it would affect your whole body, wouldn't it? Not only your mind, you get physical symptoms, you don't look after yourself, you don't have appetite, you don't feel like eating, and that affects your systems of the body, and liver is part of that. So I guess to answer your question, yes, stress can affect your liver. We haven't proven it in any particular study or a clinical trial, but yes, it can affect because of the various effects of stress it has on you, psychologically and physically. And stress is not good. Yeah.
Feel free to phone me on this. And I remember when my husband died. I mean, he died very suddenly. He was listening to me on the BBC radio, and he just died of a aortic aneurysm. And the shock was enormous. A good way for him to go. But I remember one night James Newberger phoned me just to see how I was doing. And he says, "What have you eaten today?" And I says, "Pardon?" He says, "Well, what have you eaten today?" And I didn't think to eat. So you might not be aware that you are doing or not doing things. So, have a wee think to yourself and try and get into a bit of a routine. Is what I'm saying, but happy to speak on the phone. Connie, what medication Ativan is safe to take for stress? Ativan?
So Ativan, I've just Googled it. It's lorazepam, Collette. It is a type of anxiolytic. So it's given for anxiety medication. So lorazepam is Ativan. So lorazepam, again, is like a benzodiazepine. It's like diazepam. It has got no direct effect on PBC, but it is a sedative. It can make you drowsy if you take too much of it. But in a short course treatment, it is good for anxiety and stress. But your GP needs to prescribe it. It is not available over the counter. So if you're really, really stressed and your GP wants to give it to you for a few weeks or a month, that's fine. It's safe.
Okay. And we have, they keep giving me these words I can't pronounce.
Colesevelam.
I'm glad I stuck with accountancy and didn't do anything else. Mentioned a list of its treatment. My hepatologist has recommended this to my GP in tablet form. Your views on it, please.
Absolutely. Good medication. I give it routinely to my itchy patients. It's better than the Questran that other person said it tastes like a water paint, like a paste.
Wallpaper paste,
Wallpaper paste, yeah. So colesevelam, the good thing is it comes as a tablet. It's much more palatable, easy to swallow, very good for itch. Again, I give it to my patients for about a month, and some people come back and say it's done wonders. Some people come back and say it doesn't work. So if your GP or doctor has given it to you, please take it.
Okay. Hillary's saying, can I take omeprazole? And definitely, I've been taking this for reflux since June last year.
Can I take PPI? Yes, omeprazole. Yes, of course. Yeah. Same goes for famotidine. Reflux medications like famotidine, omeprazole are safe. Should you take it indefinitely? Again, that depends on your symptoms and what your GP says to you. There is no safety data on PPIs or omeprazole for many, many years. There is some concern that these medications can cause thinning of the bone, like osteoporosis. So you need to be careful. But if you stop the omeprazole and if you get reflux symptoms, then you need to go back on it. So, but yeah, see how your symptoms go.
Ankle swelling, right? I've picked it right. So I'm on my tablet now. I've got more questions, so I'm going to fire through them as quick. You've done amazing. Diagnosed November 21, so this is early days. Started with 1,500 milligrams of Urso a day, end of December. Since then, but a lot of bile reflux, which I've never had before. This came up, Prof. Jones said this can happen. Is this a common with PBC Urso, or is this more likely an unrelated issue?
So what is that? Ankle swelling, sorry.
No, the ankle swelling, that was related. No, what this person, so they're getting a lot of bile reflux in starting Urso.
Oh, yeah.
And David Jones had said a couple of weeks ago, this is not unusual. This can
it's not. It's not, absolutely. Urso does affect your gastrointestinal system. So Urso can give you bile reflux, stomach upset, bloating, and all that. So unfortunately, those are the side effects of ursodeoxycholic acid. The way to treat that is to take small amounts, to start at a lower dose and gradually build it up. We all know the optimum dose of Urso is based on your body weight, 13 to 15 milligrams per kilo per day. But if you are getting a lot of side effects, I suggest you take it smaller dose and gradually build it up. Or the other thing you can do is divide the dose, divide the daily dose into twice a day or 3 times a day, so that your gastrointestinal system is not overburdened. But gradually you will tolerate it.
And also, although there's different companies making Urso Folk is the original one. Although the compounds are the same, or they should be the same, the capsules that's surrounding the medication can be different. So maybe a different Urso. And on the subject of Urso, you'll be receiving one of these. How do you like this? Your patients are going to have these, Vinod. This is your Urso calculator.
Beautiful. That's
so
nice.
It's in imperial and in metric weight. So as our weight changes, don't rely on your doctor to weigh you. Do it yourself. So everybody's getting one of those. Right. I have a question regarding control of my temperature. I'm so cold, it's untrue. At the moment, I'm wearing 4 layers of clothes. My hands are freezing all the time. Is there any treatment for this?
Oh, that's a difficult one. I guess it's not a PBC specific symptom, but it could go with the autonomic dysfunction that we were talking earlier. Where you're just like your blood pressure regulation, your temperature regulation is also not working well because of the autonomic dysfunction of PBC. Unfortunately, there's no treatment for this in particular, but there are other conditions which can cause a similar problem, like underactive thyroid.
So I was thinking.
Hypothyroidism can do exact same thing. So if your GP has not tested you for thyroid function, I would suggest please get it done. That's the only condition I can think of which does temperature dysregulation problem.
Prior to diagnosis, I donated blood. Can I still do it, or should I refrain? I don't think they want our blood. They never used to in the old days. Can we be donors?
That's a very good question. Medically, I don't see any reason why PBC patients can't be donors. It's not a disease that you spread from blood donation, but the NHS blood and transplant may have strict criteria. If you have a chronic disease, they may not take you as a donor. But that's not to say that they're worried about using your blood and giving it to someone else. They're probably worried about you, because if you yourself are not in a good health, then donating blood may adversely affect you. That is their thinking.
Yeah.
It's not
Yeah.
to suggest that transfusing blood from a PBC patient into a normal person gives PBC. No, we know that it doesn't. It's not a blood-borne disease. It doesn't transmit from person to person.
Mm.
It is to protect you, as in you have a PBC, you have a liver condition, and therefore you're not a suitable donor for blood.
Yeah.
Hope that answers.
Look after yourself, in other words.
Yeah, exactly. Yeah,
So-
there are other million population in the country they can donate.
Absolutely.
Blood.
I have an appointment for a CT scan with contrast next week. After speaking to the liver clinic, they confirmed my liver consultant has requested it. Okay. I had an ultrasound in November, which showed my spleen was large. FibroScan score 25.7.
Yeah.
AMA positive, SB 100 positive, ALP 422, ALT 1 of 4. Why am I having a CT scan with contrast, and what is my consultant looking for? That's a very difficult question to ask a doctor who knows nothing about you apart from this small piece of information.
Yeah.
But I would be really reassured that her doctor is looking after, and he wants to keep a closer eye.
Yeah.
Do you want?
Yeah, that's all I can say. And there are some slightly worrying things there. Obviously, FibroScan reading is high, spleen is a bit enlarged on the ultrasound scan. And the CT scan, in a very generic type of answer, the CT scan is done to look at the liver in total. What does the liver look like? The morphology of the liver, as in, does it look irregular? Does it look shrunken? Does it have any appearance of cirrhosis? Number one. You also do the CT scan to look at the if there is any liver lesions. As I said earlier, cirrhotic PBC can give you liver cancer. So CT is also done for looking for liver cancers. And CT gives you a lot of information about your abdomen. It gives you, are there any features of portal hypertension? Are your blood vessels that go into the liver and come out of liver, are they patent? What size are they? So there's a wealth of information you can get by doing the CT scan. If your doctor has recommended it, please get it done.
Yeah, I think you're being very well looked after, and please, and don't forget, look at trends. They don't just look at one snapshot. They like trends. But just to make you laugh, I had my CT scan last year, whatever. My consultant wrote me a nice letter, and he says, "Oh, by the way, they did notice that your spine had deteriorated a bit with age."
Yeah.
And I was thinking, but they were looking at my liver.
Yeah, absolutely. Yeah.
Right. Can itching on my stomach be down to PBC?
Sorry, can I come again, Collette? Can I?
Itching on my stomach, my tummy, can it be down to PBC?
Itching on stomach. Yeah, it can be. Itching in PBC can affect any part of your body. It generally affects your hands and sole of your feet, but it can be quite generalized. It can be on your torso, on your back, on your stomach area. So itching can happen anywhere or on your body in PBC. So yeah, it can be.
I'm a non-responder to all medication for PBC. I'm currently waiting to do a trial. My question is, why do I feel so sick every day, and I'm sick all day, 3 days a week? This gets me down, and I can't eat on these days.
Yeah, sorry about that. ERSO non-response is not a good thing to have. But there are second-line medications for ERSO non-response, as you know very well. If you haven't responded to ERSO, you could have obeticholic acid, or you could have bezafibrate. So please speak to your
doctor. All PBC medications, so I'm assuming that they've been tried on ERSO.
Yeah, they probably have. Maybe it's a very rare thing to have a side effect to all the medications. Then I guess your body just doesn't like any of the medications.
And the sickness, 3 days a week, being very, very sick. Can she be prescribed antisickness?
Yes.
Sometimes?
Absolutely. Sickness can be controlled.
Yeah.
Sickness can be controlled. Again, I would like to know what your bilirubin, alkaline phosphatase, and other things are doing, because when your liver is not working very well, let's assume, then you will get symptoms of sickness, nausea, anorexia, not able to eat things. So, those symptoms can be a marker of your liver health. So there are medications that you can be given to control your symptoms, cyclizine, ondansetron. These medications are for sickness, and they're safe in liver problem.
Okay, we've somebody said, how do you get the URSO calculator? We're going to send them to everybody in the UK. Out with the UK, we'll pop them online for you, and they'll go in the app as well. So that's fine. Do you recommend periodic abdominal ultrasounds?
Only if you have cirrhosis.
Yeah.
Only if you have cirrhosis, proven cirrhosis, you will need ultrasound scan of the liver every 6 months. That is the universal standard of care for every patient with cirrhosis, whether it's PBC or anything else. If you don't have cirrhosis, you don't need regular ultrasound scan.
Okay.
There's no need for it.
Can I clarify a question? I'm AMA positive, but my LFTs are normal.
Yeah.
ALP is low.
Yeah.
However, I have terrible fatigue. Should I be taking URSO?
No. Answer is no. URSO, well, 2 reasons for that. One is you don't have PBC by the definition. If your ALP is normal, but you have the antibody, we can't diagnose you of PBC. Number one. But fatigue can be a symptom of pre-PBC. And there are lots of other causes of fatigue that you need to be looked into and ruled out. And URSO is not a treatment for fatigue. So those are the reasons why I wouldn't recommend URSO in your case. Fatigue does not respond to ursodeoxycholic acid. So
no, but movement is medicine does. It comes
Yeah.
highly recommended. Movement is medicine. And I remember hearing it years ago from that lovely Canadian doctor, and I thought, he's mad. He doesn't understand what it's like to be tired.
Yeah.
He was absolutely right, and I was wrong. But I would say to this person as well, maybe go back and get your thyroid checked. Look
Yes.
at other things as well. It's not just PBC, anemia, all sorts of things.
Yes.
I only have a mild itch. Last summer before diagnosis, I took Piriton. Is this a good idea or not? If it works.
I have problems with Piriton.
Well, you do, right? Okay.
A lot of patients come with it. Lots of GPs prescribe it. And I see why they have done it. It is a antihistamine. It is a little bit sedative. It gives a bit of sleep at night. And for itchy people, bit of sleep at night is godsend, isn't it? I would say if you are very itchy at night and it's affecting your sleep, take Piriton, but don't make it a habit to take it every day. Because Piriton is not a treatment for itch in PBC. It should not be given regularly. It should be sparingly used. It should be only used for nighttime sedation and only for a short course. There are other better anti-itch medications than Piriton.
A nice warm bath with Epsom salts as well. Salts reduce the itch. They use this is what they do in hospitals. Would having cirrhosis be making me sick?
It can do. Anorexia, nausea, vomiting are recognized symptoms of liver disease. Yes, it can do. Cirrhosis can give you all those symptoms. But again, depends upon how bad your liver numbers are. There are lots of stable cirrhotic patients with completely normal bilirubin. We don't expect them to vomit or feel sick.
Yeah, it just shows you the vast variety, doesn't it, of symptoms. And the last question, my God, you played a stormer, young man. The bloods I have done routinely are LFTs, AFP. Should I be having INR? That was
INR. Yeah, INR. So if you have cirrhosis of liver from PBC, what we normally routinely recommend, as I said earlier, is ultrasound scan every 6 months. Some clinicians also check alpha-fetoprotein, but I don't. Alpha-fetoprotein is a marker of liver tumor or liver cancer, and some people rely on it, and they look at the trend of it. If you measure alpha-fetoprotein in your blood every 6 months, and the numbers are rising, then it is a bit of a worry. But some clinicians, including me, don't believe in it. So we don't routinely recommend alpha-fetoprotein in all cirrhosis patients. INR is a very good marker of liver disease. If your INR is normal, feel good about it because it means that your liver is functioning completely well. If your INR is rising, that means your liver is failing and you may need liver transplant assessment. That's all I would say. Alpha-fetoprotein, don't worry too much about it. INR, yes, it's a good thing to have every 6 months, particularly if you have cirrhosis.
Great, you've answered every single question.
That's the record.
Beautifully, thank you. Now, I'm going to say to everybody, I hope we did you proud again. Now, try and we get more and more questions each week, and I'm very keen that we get them all answered. If you can, to help the backroom boys, my staff, there's 3 people that work in the background to these setups. I know it looks dead easy, just me with the doctor, but there's a lot to it. Try and get them in by Tuesday night, if you can, please, by Tuesday midnight. We will get all the questions, we will have them all stored, but if we don't have enough time. So, and if you're writing an awful lot of information, we have to filter it down a bit because we don't have time to do to read out everything. And it's a wee bit unfair to ask the doctors as well when you know they're not your doctor and they don't have all the information. However, Vinod, fantastic. Thank you so much.
Okay. Yeah, no,
it's been marvelous, and this has been particularly good because I know we're hopefully coming past COVID, that because people still not seeing doctors and what have you, and it gives peace of mind, information or something they can take or contact a doctor with, which helps hugely. So thank you so much. We're all very grateful. They're all saying thank you on the screen. Alan, Chris,
thank you both.
Great team. Thank you for your support.
Brilliant session.
Right, I'm going for a cup of coffee, right?
Yeah, I'm going to close down Facebook. So thanks very much to everybody.
Thank you.
Okay.
See you in a couple of months.
See you next week.
Thanks a lot.